Hello. This lecture is on informed consent. We have 25 PowerPoint slides. I ordinarily don't like to do, tell the truth, I've never done voiceover PowerPoint slides, so bear with me on this. But we're going to start with the presentation of informed consent from the book Principles of Biomedical Ethics by Tom Beacham and James Childress, a really classic text. And they give us a very good presentation. So this will be the bulk of the material that we'll be looking at will come from this, and it's well detailed in the PowerPoints. At the very end, we'll consider the two articles that are closely related to this, that by Jay Katz and the one by Beacham, by Faden and Beacham. We'll see that it's mentioned earlier. Their views are mentioned earlier in the PowerPoint slides. Informed consent by now is the requirement of the relationship between investigators and biomedical and the subjects of biomedical research, and certainly between physicians and patients. And since then, the concept has been extended to other professions, certainly other healthcare professions, but even to engineering. So it's central, really, to understanding the relation between professionals and clients. The concept gets no mention at all before the 1950s as a result of the Nuremberg trials. The Nuremberg trials were war crimes trials involving Nazi war criminals, including physicians who carried out really horrendous experimentation using the inmates at Auschwitz and other concentration camps. From that, we get from the Nuremberg trials the International Declaration of Human Rights, and specifically requirements for ethical use of human beings as subjects of biomedical research. So we get concept gets mentioned in the 1950s, and then not much happens with it before 1972. In 1972, we get the first Presidential Commission on Bioethics, which issued the Belmont Report. We'll discuss this briefly when we get to biomedical research. It's in the Belmont Report that we get a very in-depth presentation of the concept of informed consent and its requirements. There's been, we'll see in bioethics, things change over time, attitudes change. We get a shift from initially the requirements of investigators or physicians to disclose information to the subject or patient. That was the main requirement. Things are more subtle after that. Now it's the quality of the subjects and patients' understanding and their consent. This also reflects their different interests in the concept of informed consent. We need to understand that it's a legal requirement, but it's also an ethical requirement. And those two normative disciplines have different interests. And that we see that reflected in the shift from disclosure, which is more of a legal concept or a legally testable concept, to an interest in the subject's or patient's understanding of consent. Functions and justifications of informed consent requirements. Again, we see historically, it comes out of an early concern with protection of research subjects. We'll talk more about this when we get to biomedical research, but we have a history in the United States of abuse of research subjects. It's not just Nazis. And again, their more recent turn toward the protection of autonomous choice of subjects and patients. In their text, their discussion of informed consent occurs in their chapter on autonomy. Beacham and Childress are famous for their approach to biomedical ethics in terms of four main principles: beneficence, doing good to people; non-maleficence, not harming people; justice, basically distributive justice, just fair distribution of benefits and burdens; and finally, autonomy. So informed consent is mainly located within concerns of autonomy. It's a vague concept in terms of its possible forms. Some demand shared ongoing decision-making between, say, patients and physicians. That Katz will argue for something like this. That it's not a single event, not a legalistic event, but something that is shared, sort of a joint endeavor. And that would be true of biomedical research too. We do research out of a condition of ignorance. Under those conditions, there's an obligation to protect subjects, and also subjects are making contributions. So it is a joint endeavor. So the alternatives to this idea, the ideal of shared ongoing decision making, would be a single event, say a signature on a form. That's how most people understand informed consent, or in between, a temporal process that's something less than shared decision making, as this will be advocated by Faden and Beecham. So Katz will be our exemplar of informed consent understood in terms of shared ongoing decision making. Faden and Beecham, an exemplar of something less, something more practical. They will argue for informed consent in terms of institutionalized social rules, which includes a procedure involving a form and a signature. But the form and the signature are merely vehicles for having something else. Elements of informed consent include competence, disclosure, understanding, voluntariness, and consent. And most of the rest of our discussion will revolve around these 5 elements. Let's understand it this way. So we'll temporally threshold elements. What are the preconditions that of informed consent? Competence. Person can't consent unless they're competent. So we test for competence to understand the information, an ability to understand the information that's central, and competence actually to make a decision, and the voluntariness of the subject or patient. Are they free from compulsion, say? Information elements include disclosure of material information, whatever that is. We'll look at that. Another informational element, a recommendation. Sometimes that's all that patients are interested in, is the recommendation of a plan. And last, the understanding of the information disclosed and the plan recommended. Consent elements, lastly, include the decision itself and a separate authorization of the chosen plan. So, of those 5 elements, let's start with competence. This competence serves the gatekeeping role in healthcare of distinguishing people whose decisions we should pay attention to, and those whose decisions we ought not to. It's important to see that the burden of proof is on those who would deny that someone is competent. So we presume competence. Then the test is to indicate that somebody is not competent otherwise. So that means the tests we're interested in incompetence. Rival standards of incompetence there are, such as different people understand incompetence in different ways. So they're all involve some form of inability. First, the inability to communicate a choice or a preference. So we're going from minimal capacities to maximal capacities that would be required to determine incompetence. The minimal standard of incompetence is an inability to communicate a choice or preference at all. Second, inability to understand one situation and its consequences. to not be able to understand, well, exactly that, risks, benefits, that comes later, but this is more minimal. Inability to understand relevant information, to give a reason, to give a rational reason. So we're ascending the stringency of the requirements, inability to give reasons in terms of risks and benefits, and finally, an inability to reach a reasonable decision. This is a bit dangerous. There are different standards of reasonability. So if we look at these, they cluster into three groups. Once again, the first is the weakest, depends just on the ability to express a preference, like to indicate pain, perhaps even. Standards, the second and third standards require increasing abilities to understand information. So standard 2, to understand your situation and consequences, and third, to understand relevant information. And the last 4 are all revolve around reasoning capacities. So once we determine what kind of incompetence is relevant, then we need to develop a test for it. And this would involve both empirical elements and normative as well. So first off, we establish the relevant abilities for what would be incompetence, fix the threshold level of abilities, and last, determine some empirical test for satisfying the threshold. Interesting discussion in Beecham and Childress about this sliding scale strategy. The idea here is the interest in protecting patients from making decisions which are not in their interests. This is certainly a reasonable interest at all. Physicians, investigators, and professional staff. Basic idea then is the riskier an intervention, the higher should be the level of ability required for a judgment of competence to decide. So there's a ratio here. The higher the risk, the higher the level of the ability to decide. And interests are in ensuring good outcomes, that should contribute to the way we create standards for determining competence. That these are the interests that are served. The way we create standards for determining competence. Beecham and Childress object to the sliding scale. Interesting. Let's first see a argument for the sliding scale. This comes from the bioethicists Alan Buchanan and Dan Brock, whom we'll both read later. So Buchanan and Brock say, just because a patient is competent to consent to a treatment, it does not follow that the patient is competent to refuse it, and vice versa. For example, consent to a low-risk life-saving procedure by an otherwise healthy individual should require only a minimal level of competence. But refusal of that same procedure by such an individual should require the highest level of competence. Because the appropriate level of competence properly required for a particular decision must be adjusted to the consequences of acting on that decision, no single standard of decision-making competence is adequate. Instead, the level of competence appropriately required for decision-making varies along a full range from low minimum to high maximal. The greater the risk relative to other alternatives, the greater the level of communication, understanding, and reasoning skills required for competence to make this decision. Beecham and Childress said, of course, the motivation is appropriate, but what is it? What do we need to protect here? While the level of competence to decide ought to increase with the complexity of a decision, say, deciding on a spinal fusion versus taking a tranquilizer, what's required in making an informed and autonomous decision with respect to a spinal fusion is a good deal more complex than the decision to take a tranquilizer. The level of competence does not increase with the level of risk, however. Instead, they say what should be increased when the risk level increases is the level of evidence required to show that the test for competence has been satisfied. The burden of proof is on those to make sure that someone does satisfy the requirements. So the requirements shouldn't be higher. That's paternalistic. Instead, the burden is on the investigator or the physician to make sure that the patient has satisfied the ordinary requirements. So that's competence. Next is disclosure. Now, here again, we see the different interests between the law and ethics with respect to informed consent. Beecham and Childress say, as litigation over legal requirements of consent to medical treatment evolved, a more complicated set of rules also evolved, especially regarding disclosure standards. The term informed consent was born in this legal context. However, from the moral viewpoint, informed consent has less to do with the liability of professionals as agents of disclosure and more to do with the autonomous choices of patients and subjects. Both healthcare professionals and patients need to ask and answer questions, and this process is less a matter of disclosing information than of discovering the relevant information and deciding how to frame and use it. So, what sorts of information are properly required or to be disclosed to a subject or patient? 5 types. First, information that the subjects or patients themselves regard to be material to a decision. Second, information professionals regard as material to the decision that concerned. Third, the professional's recommendation. Fourth, the purpose of seeking consent. And fifth, the nature and limits of consent as an act of authorization. There are standards of disclosure on top of the information that needs to be disclosed. The professional's practice standard, Katz will have things to say about this, critical things. He's critical of this idea. That is there a standard that we can identify within, say, any medical specialty for what the relevant sorts of information would be from a physician's viewpoint for a patient to be able to make an informed consent? Second, the reasonable person standard. This is again a legal standard. We hear a lot of this so that the courts are interested in. So to determine negligence, say, what would a reasonable person have thought? The famous McDonald's coffee case. I think it's a good example here. A reasonable person on buying coffee would understand that putting it in your lap in your car is not a good idea because coffee is hot. And last, the subjective standard. The courts like reasonable person standard. The subjective standard is the individual's standard, but what any given individual would want in that particular circumstance. Now, this is ideal from a moral point of view. This is what we want. Of course, from a legal viewpoint, this is extremely vague. All right, so we need to disclose. You can have no informed consent without information being provided, but there are justifications for intentionally non-disclosing information. First off is one that Katz, again, will be very critical of, is the legal tradition of therapeutic privilege. That courts have allowed that if a physician can show that providing information to a patient would hurt the patient's interests, and in particular, the patient's health, then that is justification for not revealing that information. Say if the patient has serious heart condition, then explaining fully what the condition is might actually exacerbate the patient's condition. Second, the therapeutic use of placebos. This is really tricky. Placebos are. Here's a good example that they give of this. So placebo, of course, is a sugar pill. It's something that works and improves a patient's condition based on the patient's not knowing that they're receiving the placebo. We'll see when we get to research ethics in randomized clinical trials. Very often, placebos are used. So one arm of the trial will receive, subjects will receive the intervention that we're interested in. The other arm might receive a placebo instead. A sugar pill, does nothing chemically. So it depends on deception. Of course, that's the ethical problem with it. Here's our case. Mr. X had undergone several abdominal operations for gallstones, postoperative adhesions, and bowel obstructions, and subsequently experienced chronic pain. Became somewhat depressed, lost weight, had poor hygiene, was unkempt, and withdrew socially. After using the addictive drug Toluene 6 times a day for more than 2 years to control pain, he had trouble finding injection sites for the Toluene. He sought help, quote, to get more out of life in spite of pain, and voluntarily entered a psychiatric ward that used relaxation techniques and other behavioral procedures. In the ward, he successfully reduced his Toluene usage to 4 times daily, but insisted that this level was necessary to control his pain. His therapist decided to withdraw the Toluene over time without his knowledge by diluting it with increasing proportions of normal saline. He experienced withdrawal symptoms of nausea, diarrhea, and cramps, which he thought were the result of the Elavil, which the therapist had introduced to relieve the withdrawal symptoms, again, without informing him of the purpose. The physicians gradually increased the intervals between injections of the saline. X was aware of these changes, but did not know that the injections contained only saline. After 3 weeks, his therapist informed him of the placebo substitution. After his initial incredulity and anger subsided, the patient asked that the saline be discontinued and self-control techniques continued. When discharged 3 weeks later, he could control his abdominal pain more effectively with the self-control techniques than he would have been able to with Toluene. 6 months later, he was still using self-control techniques and had resumed social activities. The therapists defended their deception on the grounds that they felt ethically obliged to use a treatment that had a high probability of success. Yet, they said, we saw no option without ethical problems. Although it's precarious to justify the means by the end, we felt most obliged to use a procedure designed to help the patient achieve a personally and medically desirable goal. So, as Beecham Children says, they argued in effect that the principle of beneficence overrode respect for autonomy in this case. This isn't very thoughtful consideration on their part. This is how ethics works. So, placebo use. Next, withholding information, in particular from research subjects. Many examples of this. Generally, this is very problematic. Obviously, one of the idea being that you want to enroll subjects in your trial. Provision of certain information may discourage them from enrolling. Obviously, that's unethical. Some instances of withholding information the consensus is that it is justifiable. Usually, this happens with epidemiological research when you're dealing with populations rather than individuals. Next, understanding. They say professionals asking questions, eliciting concerns and interests of subjects and patients, encouraging subject-patient questions is often more effective in producing understanding than is the disclosure of information. One problem is that there's no consensus as to what constitutes understanding. And there's no consensus as to how to obtain understanding, what information needs to be disclosed again to get the relevant, to get the understanding that we're after. Some facts are irrelevant or trivial, others are vital. Here's this case of Bang versus Miller Hospital, where patient Bang did not intend to consent to sterilization that's entailed by prostate surgery. He did give a formal consent to prostate surgery, but without being told that sterilization was an inevitable outcome. Sterilization is not necessarily an inevitable outcome of prostate surgery, but it was in this particular procedure. It's a Bang's failure to understand this one surgical consequence substantially compromised what was otherwise an adequate understanding and invalidated what otherwise would have been a valid consent. Part of the problem also is background information. This is a real problem, obviously, between professionals and clients, particularly in the consulting professions, when you have your client right before you. This is not the case usually with engineering, of course. It is with nurses. It is with physicians, with dentists, and so on. Samuel Gorovitz, bioethicist and philosopher, gives a very nice example of this, that, well, one problem is just terminology. Say stroke or hernia will mean one thing to lay people, to many lay people, something quite different for professionals. And this is something that professionals often don't understand, the level of the background information that clients, the lack of information that they're subject to or understanding. So Gorovitz gives this example. We have a child who's to receive a surgical procedure, cardiac procedure, the next day. The surgeon gets the resident to obtain a proxy consent from the child's parent the night before. So the resident is very conscientious, explains the procedure in part by drawing a diagram, basically a box with inputs and outputs for blood flow through the heart. So the heart has 4 chambers. Blood comes in here. It's pumped out to the lungs to be oxygenated, is returned to the heart, and then is pumped out to the rest of the body. The problem is that your baby has a small hole between these 2 top chambers. This is a fairly common anomaly. We go in, we'll close it up, everything should be okay. So far so good. But then he asks the mother to explain what the problem is herself. And she says, the problem, remember the initial, the diagram is very simple. It's a box. So she says, problem is that my baby has a square heart. So she never got around the noise of the diagram. How could you anticipate that? That's how messy the notion of understanding is. And of course, that's a necessary concomitant of professional practice, because there's the esoteric knowledge that professionals have that clients lack. That's the whole reason why clients go to professionals, is because of the knowledge that professionals have that they do not. So it's a function of that clients don't have the understanding that professionals do. Other problems of information processing. Information overload is very common, of course, and just as likely as under-disclosure to produce uninformed decisions. And then a very interesting phenomenon of framing effects. Framing effects are violations of invariance. Invariance is a requirement of rational decision-making. It says that it should not matter to one's choice how the options are stated. That is, as long as they're stated accurately, how they're actually stated shouldn't matter. Here's an example. One study asked radiologists, outpatients with chronic medical problems, and graduate business students to make a hypothetical choice between 2 alternative therapies for lung cancer, surgery and radiation therapy. The preferences of all 3 groups were affected by whether the information about outcomes was framed in terms of survival or death. When faced with outcomes framed in terms of probability of survival, 25% chose radiation over surgery. However, when the identical outcomes were presented in terms of probability of death, 42% preferred radiation. The mode of presenting the risk of immediate death from surgical complications, which has no counterpart in radiation therapy, appears to have made the decisive difference. Another very simple example of this would be, say, a cardiac surgeon discussing with a patient possibilities of a cardiac bypass procedure. And the surgeon says, well, you have an 85% chance of coming through the procedure. Now, the patient would quite possibly see his odds of being quite different had the surgeon said instead, you have a 15% chance of not making it out of the operating room. Same odds. So of course, how do we obviate this problem? It's a very common problem. Well, stated in both terms. You have 85% chance of making it through. Of course, that means you also have a 15% chance of not making it through the procedure. Problems of non-acceptance and false belief. You may disclose the information, make sure it's adequately understood, and people will still not accept it. Professionals, I think we're appreciating this more than we used to, but this is a real problem that people, because they possibly, I don't know why this is possibly, it's because of the availability of information now on the internet, that people feel that they are as well informed as their physician might be. At any rate, information that they accept and understand, they may still reject. And they may have actually false beliefs, which they'll continue to retain. Here's an example. A 57-year-old woman was admitted to the hospital because of a fractured hip. During the course of the hospitalization, a Pap test and biopsy revealed stage 1A carcinoma of the cervix. Surgery was strongly recommended since the cancer was almost curable, certainly curable by hysterectomy. The patient refused the procedure. The patient's treating physicians at this point felt that she was mentally incompetent. Psychiatric and neurological consultations were requested to determine the possibility of dementia and/or mental incompetence. Psychiatric consultant felt that the patient was demented and not mentally competent to make decisions regarding her own care. This determination was based in large measure on the patient's steadfast, unreasonable refusal to undergo surgery. The neurologist disagreed, finding no evidence of dementia. On questioning, the patient stated that she was refusing the hysterectomy because she did not believe she had cancer. Anyone knows, she said, that people with cancer are sick, feel bad, and lose weight, while she felt quite well. The patient continued to hold this view despite the results of the biopsy and her physician's persistent arguments to the contrary. Physicians considered overriding the patient's refusal. In this particular case, the patient was a poor white woman from Appalachia with a third-grade education. The fact that her treating physician was Black turned out to be the major reason for her false belief that she had no cancer. She would not believe what a Black physician told her. However, intense discussions with a white physician and with her daughter eventually resulted in a change in her belief and a consent to a successful hysterectomy. So continue to question why somebody would have the false beliefs that they hold. Another problem of waivers. This is interesting. That, of course, an informed consent requires everything we've mentioned so far: disclosure, understanding. But then people can freely choose not to be informed. What do we do with that? That's an exercise of their autonomy in a sense. So, in the exercise of a waiver, a patient voluntarily relinquishes the right to an informed consent. The patient either delegates the decision to the physician or asks not to be informed. I'll take my chances. I don't care what the information is. I know what I want to do anyway. There are two approaches, Beecham and Childress say, two waivers. Two options. First, withhold the procedure until the patient you're satisfied is adequately informed. The second, you could proceed with only the patient's understanding that the patient is waiving the right to be informed, so that we ensure that the patient is freely choosing not to be informed. They say the second alternative may be understood as a valid consent if not an informed consent. Hence, it would provide some justification. Finally, voluntariness. We need to look at this here. An action is understood to be voluntary to the extent that it is willed without being under the control of another individual. Now, we should note, we've discussed voluntariness, of course, in conjunction with responsibility. This is then a more limited understanding of voluntary action than that which we derive from Aristotle. In Aristotelian terms, this understanding makes an action voluntary if it is neither compelled by another person or performed under duress caused by another person. So, more specific. How do we tell whether an action that is voluntary or not? There are three forms of influence that we're concerned with: coercion, persuasion, and manipulation. Coercion is, by definition, wrong. It involves either a threat or actual force used against somebody. So it's purely objective. Persuasion is convincing another person through the provisions of reasons. So we're appealing to a person's rationality when we persuade. Manipulation, this is the most difficult and the most difficult to identify, is influencing another person through means other than coercion or manipulation. So they say the essence of manipulation is swaying people to do what the manipulator wants by means other than coercion or persuasion. It's information management largely. Many forms, say, lying, withholding information, misleading exaggeration to cause persons to believe what's false. The sequence in which information is provided. Some of them are very subtle. Of course, if we want, it's all else being equal, coercion and manipulation are wrong. Persuasion is justifiable. Persuasion enables autonomous choice, while coercion and manipulation subvert it. So with persuasion, we're enabling somebody's capacity to make a decision by providing good reasons. The good reasons which should, as Kant would say, if a reason is a good one, it's a reason for anyone. It's not just the person deciding, but it ought to be a good reason for anyone else too. There's nothing wrong with that, with persuasion, all else being equal. All right, so that is the end of Beecham and Childress. Now, very briefly, the two articles in our text, first by J. Katz. Recall, Katz is the advocate of the mutual decision-making, the sustained. So throughout the physician-patient relationship, patients and physicians would together, same for investigator and subject, make decisions together. Katz, the piece in our book is taken from his very good book, The Silent World of Doctor and Patient, where he looks at the history of informed consent. Katz says that for most of the history of medicine, medicine was effective, if it's effective at all, through magic, basically. That was only in the 19th century that medicine started to be grounded in biological science. So laying on of hands and so forth was effective, but it relied on things other than objective circumstance, that is, biological conditions. So physicians were priests, basically, or acted like priests. They had all this authority, and they got the effect that they wanted by exercising this authority. This is very hard for physicians, Katz says, to let go of. So the advent of informed consent as a requirement went down hard, and it's only through generations of medical students that it's come to be accepted as standard. Canterbury versus Spence is this case that is discussed in Katz's piece. This is there are a number of cases early in the 20th century. Nathanson, Schlondorf versus New York Hospital. I think this is a case where a number of cases where, as you might expect, if somebody goes into surgery, surgeon goes in, finds that the problem is other than was thought. Another case, Moore versus somebody, sorry, don't have the name in front of me, but a patient was due to have surgery on her right ear. The surgeon goes in and finds it's really the left ear that has the problem and proceeded to do the surgery right then, and was found to have been guilty of battery, that you cannot do surgery on people without their consent, even if it is just the wrong ear. In Canterbury was a patient for a orthopedic procedure. Post-operatively, patient got out of his bed, fell, and was paralyzed as a result, and was told he sued the surgeon, and said he was not told that this was a possible consequence of getting out of his bed and falling. The case then, the importance of the case is that for the first time, courts judge that it isn't physicians who determine what information ought to be disclosed. There must be an objective standard given to them. Katz objects in part to the conflation, the running together of the concepts of medical judgment and medical knowledge. He says it's medical knowledge that we need here, that we need to distinguish knowledge from judgment. The professional's role in this case is to provide information to enable the patient to make an informed choice. It's not the physician's judgment. It's not the physician's judgment even what information is important here. And that's what Nathanson determined for the first time. So we actually have part of the text for the decision in our book right before the Katz article. In the decision, Judge Robinson says, respect for the patient's right of self-determination on particular therapy demands a standard set by law for physicians, rather than one which physicians may or may not impose upon themselves. They discuss therapeutic privilege here, that it is justifiable on occasion. Judge Robinson allows. He says, it's recognized that patients occasionally become so ill or emotionally distraught on disclosure as to foreclose a rational decision, or complicate or hinder the treatment, perhaps even pose a psychological damage to the patient. The critical inquiry is whether the physician responded to a sound medical judgment that communication of the risk information would present a threat to the patient's well-being. Katz is very skeptical of therapeutic privilege, saying that the number of occasions on which it's justifiably invoked are very few. So his first objection then is to the running together of medical judgment and medical knowledge. His ultimate objection to Canterbury is the standard. So on the one hand, it sounds very good that for the first time, the courts are saying the standard of disclosure is not up to the physician. It is given to the physician. We've looked at this already. What are the standards of disclosure? Professional standard, reasonable person standard, subjective standard. The Katz argues there is no professional standard. As we saw in the case of the woman not accepting information, having false beliefs about it. Saw a difference between the psychiatrist and the neurologist. There often is no consensus. There's often no consensus within a medical specialty. So what happens? Katz says what happens is that because there is no consensus that you can point to within a profession, And of course, this is where the courts are looking. So the objective standard, what they want to do is to take the decision away from individual physicians. But of course, it has to be a medical standard. We're talking about a profession of medicine. So the experts, those who can decide what the professional standard is, would have to be physicians. But since there is no consensus in even a medical specialty, Katz says that the decision ultimately devolves back to the individual physician anyway. And so it was an ineffective judgment. Katz would like the form of informed consent of the three forms that we mentioned as far as a procedure goes: mutual decision making, ongoing mutual decision making between professional and client. Now, the problem with this is that mutual decision making requires disclosure on a regular basis of information. And this, in our time, is impractical. Say, Faden and Beecham, in their piece, which won't take much time at all with, because we've already discussed it, they make the distinction. It is they who distinguish between the two senses of informed consent. Either basically Katz sense, autonomous authorization, which ideally would involve ongoing provision of information. And because Faden and Beecham say that's impractical, particularly under contemporary conditions of healthcare. Physicians just don't have time to provide that amount of information that's addressed to the particular needs of this patient. They have to learn the patient. They have to learn what's material to the patient. The patient may be terrified of some particular form of cancer, and their condition may have nothing to do with that, and yet it's material to that patient. Those sorts of situations make it impractical to demand autonomous authorization. So we fall back upon social rules, they say, of consent, which isn't just a procedure, just signing a form, reading the form and getting the signature of the patient, but rather it's ongoing. Again, that when relevant information appears, it must be revealed, disclosed to the patient. So it's something between signature on a form and the Patch Adams kind of medicine that Katz advocates, which would be ideal. But since it's not practical, we need something else. That's the sense too of informed consent that Faden and Beecham argue for in their piece. So that is informed consent. Next time, we'll look at a particular form of it. Lainey Friedman Ross's piece on mature minors being able to give consent for life-saving procedures or to refuse it.